Hello everyone. Today I'll be speaking on rational use of diuretics. There is nothing to disclose. The objectives of today's talk shall be to learn about different diuretics, how to use furosemide and other loop diuretics correctly, what are the mechanisms of diuretic resistance, and how we can overcome diuretic resistance. The dumbest nephron is smarter than the smartest neuron. I'll be coming to this in my subsequent slides. Caffeine is an important diuretic which we consume in our day to day life, be it coffee, tea, coke, chocolate, or even ice cream. It increases GFR, inhibits efferent arterial vasoconstriction, and proximal tubule sodium reabsorption. Coming to sodium reabsorption in renal tubules, proximal tubule accounts for 67% of sodium reabsorption, followed by thick ascending limb of loop of Henle 25%. Distal tubules and medullary collecting ducts account only for remaining 5 to 8% of sodium reabsorption. This diagram depicts the site of action of various diuretics along the kidney tubules. The site of action for all diuretics with the exception of spironolactone is in the luminal space. Glomerular filtration has a minor role in diuretic entry into urinary compartment largely because all diuretics are bound to protein and then they are delivered to the luminal site of action by organic anion transporters that are expressed in the straight segments of the proximal tubule. The intrinsic secretory capacity of proximal tubule controls the quantity of diuretic that enters the proximal tubule to be carried to distal site of action. It is very important to remember the bioavailability and half-life of different diuretics. Furosemide has a variable bioavailability and the half-life is 1.5 to 2 hours, which is prolonged in chronic renal insufficiency. Torsemide has got a bioavailability of 80 to 100% and a half-life of 3 to 4 hours, which is again increased in patients of kidney insufficiency. Thiazides, especially chlorthalidone and indapamide, have a longer half-life and have to be used only once a day. Potassium sparing diuretics, both amiloride and spironolactone, have also to be used once a day. Another important concept for loop diuretics is the threshold and ceiling dose. Threshold is the minimum dose which is required to produce natriuresis. For a diuretic naive individual, the dose of furosemide is 20 mg orally, while the ceiling dose for a diuretic naive individual is 80 mg of furosemide. In patients who have edema, oral dose might not be able to reach that threshold, so it's very important to use loop diuretics in the intravenous form to achieve the threshold dose and to achieve adequate natriuresis. Let's talk about mechanisms of diuretic resistance. The most important ones are the insufficient delivery of loop diuretics to the kidney tubule. For example, if you have gut edema, then there is a variable GI absorption of furosemide. Also in states of hypoalbuminemia, either it is due to nephrotic syndrome or cirrhosis of the liver, less delivery of diuretic occurs to the kidney. The third important cause is decreased kidney perfusion, especially in conditions of heart failure. The fourth one is competition for transport channels. The kidney tubules have organic anion transporter 1 and 2, and conditions like uremia, which have small molecules urea, and NSAIDs, they inhibit OAT1 and OAT2 and decrease the diuretic entry into tubular lumen. Lastly, but not the least, reduced kidney function secondary to chronic kidney disease results in decreased functional nephron mass, as a result of which you have less sites for loop diuretic to act on. Also, heightened sodium avidity, to which I'll come in a moment, is a very important cause of diuretic resistance. Let's see what happens if you give furosemide once a day. So initially there will be a phase of natriuresis which would last for 3 to 6 hours. Subsequently, for next 16 to 24 hours, kidneys would try to retain salt and water. That's why it's very important to give furosemide in at least twice daily doses, except for conditions where kidney function is less than 15 to 20. Also, try to restrict salt intake, otherwise the person would end up in positive salt balance. Let's see what happens when you start treating somebody with ECA volume expansion with loop diuretics. The first dose gives you maximum natriuresis. Subsequently, there is a breaking phenomena whereby subsequent doses you don't have that much natriuresis and you don't lose that much weight and body water. This is because there is an adaptive phenomena which occurs secondary to volume depletion, neurohormonal activation, and proximal tubule and distal tubule sodium absorption. Normally, if you continue to use these loop diuretics for a longer period of time, it turns into a maladaptive phase whereby the distal tubules become hypertrophied and hyperplasic, as a result of which your urine output falls and there is more and more salt retention and water retention. To overcome this problem, one should try to add thiazide diuretics, especially metolazone or chlorthalidone, which are long acting, and in animal models they have shown to reverse structural adaptation and have been shown to inhibit pendrin system. There are no fixed algorithms or guidelines how to manage heart failure in emergency room. Some people just increase the dose from oral to intravenous, but a rule of thumb which I've tried to follow is to increase the dose to 2.5 times the home dose, or if you are using intravenous at the same dose, then try to add metolazone at least once a day or twice a day depending on the renal parameters and the dose of furosemide. There are now equations which can predict how an individual would respond to furosemide. This equation is called natriuretic response prediction equation, where you measure the urine sodium level at 2 hours after giving furosemide injection. You put those values along with serum creatinine and urine creatinine in this formula, which is shown in this diagram. The value of sodium in millimoles which you get tells us the sodium a person would excrete over the period of next 6 hours after giving furosemide injection. Normally, you would say that if this value turns out to be more than 100, there is a good natriuresis, and if it is more than 150, then you would say it's an excellent natriuresis. Anything less than 50 in this equation would tell you that the person is less likely to respond to the current dose of furosemide and would either need a higher dose of furosemide or would need an addition of a subsequent distal diuretic. The use of loop diuretics in chronic kidney disease is always challenging. Although a reduced GFR limits the effect of a diuretic in patients with chronic kidney disease, adaptive increases in fluid delivery from the proximal tubule together with transporter overexpression both in loop of Henle and distal tubule preserves diuretic response even in patients with advanced CKD. Once the GFR is less than 15, only 15% of loop diuretic is secreted into the tubule. So you need to give a higher dose of loop diuretics to achieve a threshold. However, ceiling occurs at a dose of furosemide 160 to 200 milligrams intravenous and torsemide 80 to 100 milligrams intravenous. Same for thiazides, you need to have a higher doses, especially with hydrochlorothiazide, you would need to give 50 to 100 milligram, or you would prefer metolazone or chlorthalidone, which are again long acting and relatively more potent diuretics. People have tried adding acetazolamide to loop diuretics. It's a carbonic anhydrase inhibitor, acts in the proximal tubule and produces brisk alkaline diuresis. However, a larger RCT called ADVOR is underway, and the results of it would tell us whether we should be combining acetazolamide or not to loop diuretics. Similarly, SGLT2 inhibitors, which again act on proximal tubules, could also be added to loop diuretics. I'm not going into the details of SGLT2 inhibitors, but we all know that they have cardiorenal protection. There have been trials with V2 receptor antagonists like tolvaptan, which inhibit antidiuretic hormone. Principal feature is water diuresis. Everest trial was done, but it didn't show any improvement in natriuresis. Spironolactone or eplerenone, which are mineralocorticoid receptor antagonists, can also be added to loop diuretics. Similarly, amiloride and trimethoprim could be added. They do not have much effect on sodium loss. However, Athena heart failure trial showed there was not much improvement after adding spironolactone to natriuresis, but we all know the cardiorenal and antihypertensive effects of these drugs, and they should definitely be used, especially in those patients who have hypokalemia with loop diuretics. A strategy called hyperdiuresis and chloride repletion has been in use for last 10 to 15 years. However, none of the guidelines recommend it. Personally, I have used it couple of times. A bolus of 3% hypotonic saline 150 ml is given over half an hour. It helps in drawing out interstitial fluid by way of osmosis and blocks renin-angiotensin system. Large RCTs like SPAC heart failure study have shown beneficial results. However, I would recommend it to be used only in desperate situations when other measures have failed. So friends, I would like to conclude by following take home points. Furosemide should be used twice a day and torsemide could be used once a day. Try to use combination of furosemide either with spironolactone or amiloride in those patients who have hypokalemia, or use furosemide with metolazone or long-acting chlorthalidone or indapamide once a day to prevent diuretic resistance. Salt restriction forms the cornerstone of management of diuretic resistance and heart failure. Thanks for your patient listening.